Multiple sclerosis remains one of the leading causes of non-traumatic disability in adults age 18 to 65. And it is one of the most complex clinical areas that we navigate as occupational therapy practitioners. Because the symptoms can be so variable and complex, it can be a challenge to feel confident in our treatment plan, leaving us wondering, one, how do we select the most effective assessments to capture a patient's true functional status? Two, what's the latest evidence say about specific interventions for fatigue and exercise? And three, how can we refine our coaching and patient education to promote dignity and participation? Today, we are going to dive into the latest research and share practical, actionable strategies for MS care. We'll be joined by Makeda N. Jackson, OTD, OTRL, MSCS, a multiple sclerosis certified specialist who works in an outpatient neuro setting. We have a lot to cover today, so let's dive in. Welcome to the OT Potential Podcast. I'm your host, Sarah Lyon, OTRL, and I wanted to let you know that this podcast may qualify as continuing education for you. You are probably listening to this podcast on a free podcast platform, but to gain CEU credit, you will need to be a member of the OT Potential Club, our OT continuing education platform. You can go to otpotential.com to learn more. Okay, here we go. As I mentioned at the top, we are joined by Makeda N. Jackson. Makeda is a doctor of occupational therapy who studied at Washington University School of Medicine in St. Louis. She is interested in neuro rehab, cognition, mental health, and program development. Makeda aspires to enable individuals to live with dignity and purpose by promoting agency, participation, and spiritual and emotional wellness. So without further ado, we will patch Makeda into our live studio. Welcome, Makeda. It's so great to have you here.
Hello. Thank you so much for having me. I really appreciate it.
Oh, I am so thankful for your time today, and I'm so looking forward to this conversation. We have covered MS on the podcast before. About a year ago, we had Sarah Adams on, who is an OT who has MS and is also a Paralympian. And around that time, we started to put together an OT treatment guide for people to reference. But we kind of paused 3/4 of the way through because I was like, I really want to find a practicing clinician to have on the podcast and just run the resources by. And so that kind of set off almost a year of me looking for an OT working in neuro to speak to this topic. And I'm so thankful that we were able to find you, and you're joining us today in the middle of your workday. So I'm so thankful that you're taking time between patients to be here. To get us kicked off, I want to just learn a little bit more about you and your story. And let's start with just where your professional interest in MS treatment came from.
Yeah. I became interested in MS when I was a student, actually. I actually came into OT school wanting to do pediatrics, but the program did a really nice job of trying to expose us to lots of different practice areas. And so I really found MS. I found it interesting in that it's one of the diagnoses that can impact so many different parts of your body, as many progressive diagnoses and neurodiagnoses do. But this is one where you can make a change. You can show more functional progress and help people improve, not just maintain their status and kind of where they're at. And so there are, multiple variations or phenotypes of MS. And so people have many different presentations in terms of how they will come to you, what stage of life they'll be at, what stage in their diagnosis they'll be at. But it's really cool to be able to promote self-advocacy, promote health management, self-management, and be able to kind of provide some encouragement to say that, yes, this is, we may be able to make change. We may be able to improve your symptoms and therefore improve your quality of life and your ability to go about your day. And so I've had the opportunity to treat some patients in acute rehab, which is where I got my start after school. And now I've been in outpatient rehab for almost 3 years, about 3 years. And so I have also been able to see the continuum of care in terms of being able to treat MS patients and what that looks like in an acute care setting, what that looks like in an outpatient setting, and really be able to develop relationships and kind of track progress and see how people move along. So it's really fun for me.
Yeah, when I think of seeing patients with MS, those patients from my caseload like really popped to my mind. Like I worked in a small rural hospital and did outpatient, and so these patients stood out on my caseload as being a lot younger than a lot of my patients. And for me, or there's such a connection to actually to starting this podcast and the OT Potential Club, because MS was a condition where I would see someone like once every 1 to 2 years.
Mhm.
And this complex someone with this complex condition would walk through my door, and I would just feel like unprepared and felt like there were people like you who did this work on a regular basis. And I just wanted to know, like, what are the neuro OTs doing with their MS patients or people who work in MS specific facilities, and how can we be sharing that knowledge more broadly with OTs? So I'm so thankful to find a neuro OT. I would love to just like learn a little bit more about your setting. One of the questions I want to be sure to ask is I'm always like, I know with MS and with Parkinson's, we want to see people as early in the disease process as possible. I've never been a part of seeing someone earlier. Like, I've only seen people later when things have gotten really tough. So I would just love to hear about your setting and just like the general trends of when people tend to get to therapy.
Yeah, I'm in an outpatient neuro facility, as you mentioned, and most of the time we see quite a few MS patients, and a lot of the time, people are in their usually like 40s, 50s prime frame, and most of the time because it's outpatient. People are often not coming to us for the first time for, right after they got diagnosed. And some people may or may not have had therapy right after they got diagnosed. You'll hear, like during an eval, you'll ask people what experiences they've had with therapy, whether that was outpatient, acute rehab, even therapy and acute care. And some people will tell you that they have not received services earlier on, which is understandable. As we'll talk about a little bit later, you want to refer people early and get people in as fast as possible, especially because self management and health management can really assist people in managing and preventing a significant decline, try to prevent or at least elongate the period between relapses. So quite a few people are usually here after maybe several years after they have been diagnosed.
I wanted to kick us off by, uh, or I wanted to from the top, like lead with some of the new research that has come out since even a year ago when we covered this topic. There's been some really interesting studies that have come out and really built on what we already knew. One that I want to call out explicitly is called the beneficial impact of physical activity on multiple sclerosis disability progression. This was with a Swedish cohort of around 3,000 individuals, and they were able to track these individuals for about 15 years. And this study really builds the case that exercise seems to be almost disease modifying. Like, I feel like we keep building the case towards that. Like, we can't quite say it yet, but it's really, the evidence keeps building towards that exercise can just have this big impact for patients. And what I love about this article, I'm going to include this in our treatment guide, is it gives like a very clear breakdown of low amounts of exercise, which is under 2 hours a week, moderate, which is over that 2 hours, and you're doing one explicit exercise session that's at least 30 minutes, and then it goes up to 2 more levels. And with each higher level you get to, there's really clear benefits for the patients. So I love, one, that we can just see this disease modifying evidence building, and two, we're really building towards almost clear prescriptions for amounts of exercise.
Mhm.
It felt like a couple years ago, even the recommendations were like kind of vague, like be sure to exercise. And then the other article that I want to highlight is these are both in our show notes, but it's called The Comparison of Different Exercise Modalities on Fatigue and Muscular Fitness in Patients with Multiple Sclerosis. And from this, I'm also going to pull a table where there's just really clear, I want to say, guidance for us of the different types of exercise and the recommended like optimal amounts to modify one fatigue, and then the other is muscular fitness. And it's kind of like you do different exercises to target these two different areas. And I had honestly never seen that level of like prescription in exercise, like in any of the conditions that I've looked at. That like really jumps out to me, seems really helpful. How does that research hit you?
No, I love that. It's really cool. I remember reading a little while back, it was like a systematic review. And in that systematic review, they covered lots of different types of treatments for MS patients, specifically for occupational therapy. But one of the key factors was exercise and how beneficial that was across different symptom categories in ways that others were not. And so I think that is such a great thing to be able to give your patients something actionable to do, and show them that there is evidence to support that this can help you in terms of managing your fatigue, maintaining strength or increasing your strength, improving your balance. All of these things that are important in order for people to be able to do what they want to do, what is meaningful to them. And so I really enjoy that. I actually just had a conversation with one of my patients with MS last week, on the importance of exercise. And so not just doing some of the home exercise programs that we give them in therapy, but also trying to make sure that we create a sustainable program for her, or give her actionable items, give her resources, community resources, so that she can maintain that in order to better maintain the improvements that she made in therapy, but continue to improve. So I think it's really great, and especially having the really detailed information on how to encourage your patients in this way to do exercise, that there's like evidence-based information that you can really provide to people, which is great. I'm going to mention the National MS Society a lot in this,
Oh,
but
yeah.
I want to shout out the National MS Society as well. They have lots and lots and lots of great resources. I'm going to come back to them again later, but they also have some really great information on exercise guidelines, and like lists of different types of activities that you can do with patients, based on how much mobility they have, what the other types of deficits they may have. And so please check them out. They are a wonderful resource in addition to the consortium of multiple sclerosis centers. But they have
Mhm.
lots of great resources and videos for patients, so you can also reference their videos. It's great.
Yeah. Yeah, they do really stand out. Or in my work, I see the different societies for different conditions, and the MS Society really does stand out in the quality of the resources that they provide for us. I also or one more reflection on this, I just often think of the difference between like an ortho patient where you're doing a home exercise program that's like super targeted,
Mhm.
and you like hope they at least do it for a month and they meet that goal, versus working with people with our chronic conditions where you're really trying to set up something that's like, what can you do for 5 years? Like that
Yes.
is totally different.
Yes.
And what I love from the information that I'll put in these tables, like it's not just like go do bench press. It's like, it can be gardening, it can be dancing, it can be
Mhm.
singing loudly around your like, whatever,
Yeah.
like, let's find the thing that, like, fills you up and you can keep doing for over the long haul.
Yeah.
Yeah, in some ways, it's, like, more satisfying than planning a
Absolutely.
standard home exercise
Absolutely.
program.
Being able to tell somebody that, "Hey, they like to salsa dance," absolutely go salsa dance twice a week.
Yeah,
You
yes,
know?
yes.
I love that. It's fun, and especially as OTs, and our job is to, try to find those valued occupations and try to figure out how people can participate in those things. So to be able to tell somebody to just do what you enjoy doing. So in addition
Mhm,
to structured exercise, lifestyle activity, and trying to get more of those lifestyle activity changes is also really recommended, which is great.
mhm. Well, we're going to gather this information for people, both in the club where we'll have the information like linked to our assessment search. So we'll have assessments, treatments, a goal bank, and some other information. And I hope to have that out by the end of the week on Friday. And then we'll also have a public facing treatment guide. I'm always like, I want our patients to be looking at the same information that we're looking at, because it really does. This work has to be collaborative. I don't want our best practices like just behind a paywall. I want patients to have access to them.
Absolutely.
So that's our thinking about our research kind of big picture. I just want to get into like the logistics of sessions with patients. And I'd love to just start with evaluation and assessment. What things are you thinking as an MS patient walks through the door? And are there standardized assessments that you gear towards?
Absolutely. As when I'm treating an MS patient, there are lots of things that you will want to do, ask questions about in terms of symptoms that they may be experiencing. Of course, you want to do an occupational profile, and the COPM is a really great one to use, just to kind of talk about their everyday tasks, ADLs, IADLs, and how those are going. There are there are lots of other assessments I'll mention just briefly that are more symptom specific or deficit specific. You want to make sure we're asking about strength and coordination and balance, bowel and bladder management, mental health. So things like depression or anxiety. You want to ask about cognitive changes. So it's sensation, vision. Vision is often one of the first symptoms that people may experience as they're diagnosed with MS. So making sure that you are kind of trying to cover that very broad scope. And obviously, you don't have an eval is, often 60 minutes or less, depending on your setting. So you may not have time to really, really, go deep into all of these things, but at least just kind of brushing over them and making sure that you have touched on those in your evaluation. And then in terms of some more formalized assessments that you can use, there are some specific MS assessments that I like to go through with my patients. Fatigue. I didn't mention fatigue. Fatigue, of course, is the biggest, one of the biggest factors of MS. For fatigue, you can use the modified fatigue impact scale, which is a really big one that I like to use and reference throughout. So if we are tracking their progress in terms of, through progress summaries all the way to discharge, seeing if there's been a change made on that score. You can also use the MSIS, which is the multiple sclerosis impact scale, which is really nice because it covers lots of different symptoms that people may have. It includes an emotional or mental health subsection. It includes psychosocial barriers, physical barriers, cognitive barriers. So it's a nice summative assessment. I'll try to get at lots of things at the same time. You also have the MS functional composite, which looks at both like fine motor coordination, gait and ambulation, as well as cognition using the PACE auditory serial addition test. PASAT, I think, is what it stands for. But that functional composite is really nice. And in our clinic, we try to break that up. So PT will do the gait and ambulation assessment. OT does the 9-hole peg test portion of that. I've also done the cognitive portion, but if they're in speech therapy, we might, defer that to speech therapy as well. So you're getting all three disciplines are participating in that, which is really great. And then you've also got the MS spasticity scale, the MS quality of life scale. Those are also really nice and specific again to MS. And then, so I'll go down, we'll try to cover a couple of other assessments that are more deficit specific. So in terms of ADLs, I sometimes will use the FIM, functional independence measures. You can also use care tool scoring if that's what your setting uses. Coordination assessments, 9-hole peg is one that's recommended and is also included in the MS functional composite. Box and blocks is also a good one. For balance, the Berg balance scale, the timed up and go, the tug, activity specific balance scale. That last one is more of a survey and is asking patients about their confidence in their ability to perform different mobility tasks and maintain their balance during those things. We've got sensation testing. So, of course, doing a screen, making sure you include proprioception and kinesthesia in that screen, but also the Sams-Weinstein is a great one in terms of light touch and assessing even if they have deep pressure at all, but that is a nice one to use and to track as well. For spasticity, the modified Ashworth, and then, of course, for vision, ocular-motor testing. A lot of people often have ocular-motor deficits, sometimes visual field deficits. Assessing for those things and visual perception. You can use the Hooper Visual Organization Test, the MVPT3, and there are others. And for visual field testing, a lot of clinics may have access to this. The brain injury, it's like visual assessment battery for adults, I believe, by VABA. That has lots of cool stuff in there, but it also has a campometer, which will help you in assessing visual field. And then, of course, strength, MMT, dynamometers for grip strength, pinch gauges, the trail making test, A and B is what I use for cognition. And then I mentioned the PACE auditory serial addition test. So I realized that was a lot of information there. But there are many, and a lot of these, again, if you go to the national, and maybe I can send this information over too, but the National MS Society has a really nice, like, clinical assessment and intervention guide that includes a lot of these assessments that I listed, and of course many others for different deficit areas for MS, and also just some intervention techniques that might be helpful. So
Ooh.
would very much recommend checking that out. It's really well done.
Yeah, let's be sure to connect, and I'll get that from you and I'll put it in our show notes for people. As you're saying those, I'm like, of course, I would feel, or it makes sense that as a generalist outpatient OT, I would feel overwhelmed when I had an MS patient thinking about the uh, full battery that we could do. I want to ask about two specific things. One of them being vision testing.
Yeah.
I could say my confidence level with vision testing on a scale of 1 to 10 would be a 1, like very low.
Mhm.
It
Mhm.
wasn't something that I early in my career practiced at all. Now I'm super interested in vision. Yeah, what's like a easy for like a generalist like me, is there like
Yeah.
an easier thing that I might have access to that would be
Ooh.
helpful?
I think so the one some of the base things that I would do on an eval is an oculomotor screen, and there are some really good OT resources for just an oculomotor screen that you can find on YouTube. There are some like PDF documents that some other medical facilities have also that and schools have written up, so it'll give you like a nice written guide for what to do. But for an oculomotor screen, you want to look at ocular alignment, visual tracking, convergence, saccades, and I try to do a quick visual field test. But for the oculomotor screen, a simple one for visual tracking or smooth pursuits is the H test. So you just start here. So you're trying to get at all four quadrants, but you go down, up, across, down and up, and you're just trying to see
Mm,
if they can follow you. And you can do it with one eye, you can do it with both eyes if you notice that one eye is lagging or that one eye is having a hard time, or if both eyes are having a hard time in a particular quadrant, you would try to document that. For saccades, you can use pens or your fingers, and you're just trying to have patients look really quickly back and forth. Just like this. And so for our concussion patients that we see here, I often have the goal is 160 beats per minute. And so you can look up a metronome on YouTube. You don't have to do that necessarily on eval, but you're looking to see if people are able to get to the target. Number one, if they are really slow in doing it, if there's a lot of like jerky movements or if they're overshooting or undershooting. So that's an easy way to do saccades. And then convergence. So this is when you are trying to come closer towards their nose and you're asking them if they ever see your finger split into two, or if you're using a pen, if you see two. And then sometimes we'll use an actual tool to measure that on eval. If you don't have a tool, you can always just kind of hold your finger here and use a ruler or a tape measure or anything that you have access to try to measure what that distance is. And normal is, I believe, considered between 6 to 10 centimeters. I believe for PT, for concussion, for other diagnoses, you're looking at 5 centimeters, but anywhere between that range is considered normal. And then this is your confrontation testing. So you're just kind of trying to come behind them and then ask them to tell you when you see your finger.
mm.
And so try to start underneath and come up. Do you see it? Start underneath and come up. Oops, sorry again. Do you see it? Which is a nice, easy screen to do. And if you were to, type an oculomotor screen into YouTube, you'd be able to find just what I found, what I just showed you. I can also try to send you some information on that too, to put in the notes if anybody's interested. But yeah, that's a really base screen.
Yeah. Do you feel, oh, I could just like linger on this assessment piece for so long. I'll only let myself ask one more question. Do you feel like in your neuro rehab setting that thinking about vision, that is just something that's seen as like squarely within the scope of rehab therapists? I think when we get to pediatrics, there's almost like, I want to say turf war things about vision, but I'm like, in order to be for adult neuro, in order to be like treating these neuro patients, we have to take vision into account. It's such a core part of these neuro conditions. Do you feel any of that like tug and pull in adult rehab, or is that just more specific to pediatrics?
That might be more pediatrics. I feel like, at least in my experience in this clinic, PT will do some vision type things depending on the diagnosis, but often for vision, they're recommended occupational therapy if there's any, more significant visual challenges that they're having. And we try to work closely with neuro ophthalmologists as well, to make sure
Mhm.
that people are getting seen appropriately, getting the right diagnoses. And then there are some that are really great about providing specific exercises or communicating specific deficit areas that they're noticing and letting us know what specific exercises that we need to work on, which is really, really helpful. But often in outpatient adults, it's largely occupational therapists that are the vision specialists that people come to for vision therapy, as far as I've seen.
Hmm. That's just super interesting to hear, something that I'm going to like tuck away in my mind for future conversations. Okay, so you do uh, this battery of assessments,
Hmm.
moving on to goal writing. I'm always curious, like like fine print of what kind of what goals people are actually writing. That's such a key part of treatment. What does your goal writing process look like, and thinking about collaborating with patients on that?
Yeah.
Any pro tips for us?
Ooh, I feel like it's not very different from writing goals for other diagnoses, although I try to make my long-term goals more of the objective measures. So if there's anything that I'm tracking. So often for MS patients, I use the MSIS, the MS impact scale, to look at how they're self-reporting some of their symptom changes over time. And so that's a really nice thing to track, or the modified fatigue impact scale. If you Shirley Ryan, also which is a great resource. They have a lot of cool assessments, information on assessments and interventions. But I often go to Shirley Ryan's website and will look up what the MCID is for that specific assessment, if there is one, which is like the minimal clinically important difference or minimal detectable change, NDC. And so I'll try to include those. So I'm seeing if to see if our what we're doing in therapy is providing a clinical change, or meeting that threshold for what would be considered clinical change on that assessment. So those are two long-term goals that I like to write. In addition to, let's say they have a vision deficit and we're looking at improving their visual perceptual skills, I might use the MVPT. Or if they are, if there are specific IADL or ADL tasks, I'll also try to include, patient will be able to complete their ADL routine with, modified independence with use of recommended adaptive equipment and compensatory strategies. Or patient will have passed the Rookwood driving battery. Patient will achieve a passing score in the Rookwood driving battery, indicating increased readiness for return to driving, or things like that. So let's say they're working on return to work goals. Patient will be able to type at a speed of 40, likely 50 words per minute in order to, be able to return to work and achieve those goals. Or again, we can be looking at things that are more modification based. So educating patients on return to work strategies, on compensatory aids that they can use, on the requirements that an employer has in order to provide adaptations, like reasonable accommodations. So I sometimes will include education based goals as well. So patient will be able to teach back education on workplace accommodations for X job within, either with a certain degree of accuracy or a certain number of times within a session or something like that too. So those are some of what my long-term goals will look like. And then short-term goals, I tried to build toward those. A short-term goal that I always include first is a home exercise program. So making sure that you are, one, developing that it's like a whole body exercise program, and something that they can be consistent in, making sure that they know when they've overdone it. So if they have like a really strong like increase in symptoms the next day, if they have a lot of weakness and they're not able to kind of go about their everyday routine, if they're noticing a strong increase in symptoms that then subsides, it might be because they maybe overdid it the previous day or during that exercise. So making sure that they're able to teach back that information. I like to use the cognitive pacing scale as another one, as a means of kind of assessing where they are in terms of health management. So the cognitive pacing scale goes from 1 to 5. 1 is like the green, 2 and 3 are yellow, 4 and 5 are red. And so using that, sometimes we'll just use the colors and say, okay, where do you feel like you are on the cognitive pacing scale? And somebody might say, I'm in a high yellow. Okay, so maybe let's slow down just a little bit. And that's what level 3 or the high yellow range is, slow down. So after you've trained somebody in their exercise routine, if they say that they're at a red, that's too far. We don't want you to be in the red zone after you've done your exercise routine. So those I include goals based on sometimes a cognitive pacing skill or other means of their ability to assess how they're feeling, assess their symptoms, and be able to make appropriate decisions about how to go on about their day. So energy conservation as well. Those are some of the big things I try to frame things around, at least on an evaluation when I'm writing like short-term and long-term goals.
That's like so incredibly helpful. And I love how what I'm hearing in your goals just like reflects what we see in the research, where you're able, because we have more research around MS, you're able to have these long term goals that really reflect these areas that we know can be modified, like fatigue, symptom severity, and even match those with the same outcomes that we're seeing in the research. And then really prioritizing exercise and I would even use the word like interoception, like really
Mhm.
getting in touch with that self-recognition of when am I yellow, when am I red, when am I green, and that is a skill for us all to build, and especially important for our MS patients. That's awesome. That's very concrete and helpful. Thinking of treatment, I know that our treatment sessions are going to vary a lot based on people's individual goals.
Mhm.
But in general, is there a way you like to structure your treatment sessions in general? And are there go tos that you tend to have with MS patients?
Yes, I do have a general structure. I like to start off with like a gross motor activity or thorax strengthening. And I try to we want to make it a whole body strengthening exercise. So, for example, I had a lady that I was working with last week. She said one of her goals was to be able to clean different areas of her home, within, like, a shorter time frame without having to take as many rest breaks, and so building up the endurance, to be able to do that, and so I had her pushing her we mimicked vacuuming, and I had her pushing around a sled, and we used, like, kind of like a heavier rope as the cord because she has a larger vacuum, and she has a cord that she has to manage while she's going around her apartment cleaning. And then trying to add, air augmentation components to that. So, okay, you have this heavy sled that you're pushing with one arm. You're walking around without any devices. She normally walks with 2 walking sticks. So, walking without any devices, pushing, pulling, walking forwards, walking backwards, trying to get around corners, get under things, and then adding a time component. Okay, so we practiced this before. Let's see if you can do it faster. So,
Mm.
using that as an intensity gauge as well. But that's a nice that is like a functional strengthening activity. It's a whole body strengthening activity. And so I like to start off with things like that. It doesn't have to be as IADL specific as that task is. You could do, a task where you're tossing a weighted ball back and forth while standing up. We have something called the BITS, the Bioness Integrated Therapy Systems, which is this large touch screen which has all kinds of activities on it. But using that and putting some TheraBands on our arms and legs. So while you're stepping and reaching, you are getting some strengthening in, but we're also working on your visual perception and your visual scanning if you have visual deficits. There's cognitive programs in there, so you can make it a very well-rounded activity. But I like to start with those kinds of gross motor activities, and then we'll go down from there. So we'll go to a fine motor activity, or let's say there's an education component that I really wanted to focus on today. I also like to make sure within each activity, so especially within the therapeutic activity or thorax activity, that we are, creating breaks to ask about how they are feeling. So in terms of like you said, interoception, using the cognitive pacing scale or the energy pie or whatever tool that you feel like is best to use with your patient. And so I try initially to create those breaks within our sessions. And then ideally, as they are getting used to doing that and trying to use those tools to pay attention to how they're feeling and what they need in that moment, I want to kind of back off of that and allow them to initiate that. So trying to help train them to do that within your sessions. And then, like I said, I'll go down to a fine motor activity or education. So let's say that today we're talking about driving, return to driving. And so we may talk about the rules for that required state, what we are noticing in therapy based on how they are presenting, what deficits they have, whether that's vision, coordination, strength, balance to get, getting in and out of the car safely, what kinds of, vehicle modifications that you can make, how to get in contact with driving rehab, things like that. And then, or our fine motor activity for the day. But that's kind of how I like to structure my sessions. But big focus throughout your activities again is that training in self-advocacy and self-management so that they are able to use that at home and that translate easily to real life activities.
I've noticed this trend where, especially therapists I talk to who are in what I would call like more of a physical rehab setting,
Mhm.
that they'd like to start with something that gets those endorphins flowing. Do you think that's why you start with the gross motor thing, like the endorphin boost that then carries
I
into
think
the, like either the finer tasks or the harder tasks? Do you,
mhm. I
or like,
think
is
that
there a reasoning behind that flow, or does that just work for you?
I think that is a big component, one, but two, there's been and now this is research and other diagnoses, but there's been some research that if you start off with a gross motor task, sometimes that can lead to improvements in their ability to do a fine motor task. And so sometimes so that's one reason that I like to structure it that way. But two, you mentioned the endorphins. And then three, in terms of fatigue management. So maybe starting off with something that may be a little bit more challenging and then giving them a seated rest break time, like during the, education portion, during the fine motor portion, before they are leaving at the end of the day as well. So I find that works fairly well for my patients, just giving them that rest break time before they have to then leave the clinic and go home, especially if they're independently like coming here on their own. So that's also one of the other reasons.
Hmm. I personally love patient education. I try to always ask about it. When I was like skimming through the MS research out there, I saw a lot of like coaching model research out there. I'm curious what patient education looks like in your setting, and if there's like high impact patient education that you just tend to offer lots of people.
Yeah. I think that some of the things that we've talked about already. So, particularly for MS, really wanting to hone in on self advocacy, self management, and health management are some of the big
Mhm.
things, especially in terms of their being able to manage their symptoms throughout their day so they are still able to do what they need to do in life, whether that's take care of themselves or be able to go to work or drive or go grocery shopping. So energy conservation is a huge one. I like to reference the 4 Ps of energy conservation, which is like pace, positioning, plan, and then there's one more that I'm that I'm forgetting right now.
I don't know the 4 Ps.
Um,
I'll have to look them up.
but yes, the 4 Ps of energy
Okay.
conservation. I think it's like Joseph Candler has a really great handout on that hospital, but it's like pace, plan, prioritize, and then some. There's one other position. That's it. Pace, plan, prioritize, position. Those are the 4 Ps.
Mm.
And so pacing yourself. So again, trying not to do everything all at one time, making sure you're building in rest breaks or allowing for increased time between activities, planning and prioritizing what you want to do. So let's say there's maybe one big thing that you really need to get done. So maybe I devote a bunch of my energy towards that one thing and maybe I don't do anything else for the rest of the day if I can rearrange my life or I do something smaller and less energy consumptive after that activity. And so plan and prioritize kind of go together in that way. Position, just so it's more like changing how you are doing something. So let's say if you're standing, you maybe switch to sitting, maybe you switch to laying down. Or let's say if you are cooking and often you stand over the stove and maybe the heat intolerance, that creates it causes a lot of fatigue for you. So maybe either sitting down to do that or finding a different way to use like the fan over your stove to try to, get rid of some of the steam or heat that may be emanating from what you're making. But changing your position, you could move take seated rest breaks, maybe slightly away from the stove if it's something that needs to sit on the stove for a little while without you necessarily actively stirring it a lot. So things like that. Or if you need to clean and you are wanting to clean your tub, instead of trying to stand and, step over into the tub and scrub the tub, maybe sitting on like a shower chair outside of the tub and using something with a long handle on it so you can reach better. So things like that. So those are the 4 Ps. That's one that I really like to bring up
Mhm.
a lot. And it's great for self-management and self-advocacy. Another thing that I mentioned earlier, the cognitive pacing scale, and that is something that I will educate but also reference a lot throughout our session so that patients are able to then incorporate that at home into their everyday life, which can help with that pacing, the pacing P out of the 4 Ps. So how to manage when they need to take a break, when they need to be aware, okay, I'm starting to notice maybe an increase in symptoms, or I'm feeling maybe a little bit more tired than I was. Maybe I need to just slow down a little bit or pay attention to how I'm feeling. And then knowing what it feels like to be in the red zone, knowing what it feels like to be in the green zone. But those are two of the big things that I really like to reference. And then, of course, other more specific IADL tasks for patients that are wanting to get back to driving. Driving, I feel like, is a really big question that I get.
Mm.
So driving rehab, driving education, which often is making sure that you know what the requirements are for whatever state that you live in terms of if there are any policies. Like I live in Virginia, Virginia does not have a specific policy for MS, but they do have policies for cognitive impairments or things that would cause physical impairments, which may impact your ability to safely drive. So knowing those policies number one. And then two, like if you need to go to driving rehab, how to get in contact with driving rehab. If there's any assessments that we can do here, I try to educate on that and what that process looks like. And if there are, and unfortunately too, if there are patients driving who maybe should not be driving, we sometimes unfortunately have to have that conversation as well with family members. And then lastly, caregiver training and education. There's quite a few people that I've had that will come in with a caregiver, whether that's their spouse or their child or even a parent that is coming to therapy sessions with them. There are some people who don't have anybody with them, unfortunately, or don't have anybody who are available to assist them. But caregiver training is a huge one. So whether that's safe mobility, safe participation in ADLs, what to look for in terms of some of those signs of higher symptom days or higher fatigue days, how to manage that in terms of the energy conservation, activities and skills that we just mentioned, as well as, managing cognitive changes or, vision changes, just all of those things. So those are some of the big areas that I think we address quite a lot and are often the most helpful and the ones that patients find most useful.
Hmm. That's also helpful to hear. Before we head into our a couple of minutes of Q&A time, I just can't help but ask just a big picture question. Like, I love getting to talk to practicing therapists. These podcasts are always our most popular because people love to hear from therapists who are in the trenches doing the work. I'm just curious, big picture, what would you like to change about our system to provide better care? I'm going to take a leap and probably guess that you see patients that don't get the best care. Like, is that true? And how can we change things? If you could just change stuff, what would you do?
I think one of the big things, and I have a patient that comes to mind. I think there's quite a hole in that is created in our continuum of care. So, let's say a patient comes to acute rehab or acute care, and they then go through acute rehab, and maybe they go home. Either they get home health or they get outpatient. For and there is also an option for mobile outpatient. But there are benefits to going to an outpatient clinic like that I work in. We have, some of the cool equipment that patients may need or may really benefit from. However, the if you are a patient that either doesn't have great caregiving support, maybe has some cognitive deficits and changes, that's putting a lot of onus on the patient to generalize all of the stuff that we are doing to their home environment. And we can ask for pictures or videos of their setup and try to mimic that setup as best that we can. But it's still not the same thing as being able to go to your house and do a home visit and assess your bathroom, assess your bedroom, assess for environmental or safety barriers, actually see how you're transferring, how you're doing some of these self-care or IADL tasks. And so I feel like there's a bit of a hole. And even for patients that do have caregiver support, again, we're asking everybody to generalize what we're doing, which is harder than maybe, we might think sometimes as therapists, like, okay, I understand what I'm asking you to do. Is the patient and their family member able to do what we're asking them to do at home, especially if they have cognitive deficits? And so I think people can often kind of slip through the cracks in that way. And there's what I would really love is if we would be more so able to access an outpatient space where you have the fancy tools and all the things that you may need, especially for people who may be a little bit farther into their, diagnosis and may need a little bit more physical assistance, may need some of the fancier equipment. I wish we could have access to that and also be able to go home,
Mhm.
go to your house
Yep.
and assess your environment or go with you into the community to your grocery store or, wherever it is that you are doing your ADLs and IADL tasks. And so I feel like that is a problem generally for people among lots of different diagnoses. But I do have one patient in mind that I feel like it was very much a disservice that we could not do that for that patient because he really, really needed it. And I hope that person is doing okay now. I'm not sure what happened afterwards, but after he finished his plan of care here. But that would have been a really, really beneficial thing.
Mhm.
And so in conclusion, just not providing the care that is needed in the setting that it is needed and being able to provide care in the appropriate settings.
Mhm.
Um, that would be my thing, I think.
Yep. I'm just like, we have the evidence base. People should get the referral as soon as they get the diagnosis. If they don't
Mhm.
want to do therapy, they don't have to, but they should have the option
Yeah,
um, of that
absolutely.
referral. And I totally agree. The future of healthcare is in the home. Why are our rules closing out off that
Mm,
option to us?
yep.
And even down to like telehealth being inconsistent. Like
Yeah.
that's imperfect, but at least it's kind of in the home. Like
Yeah.
it's
You
just
still can
time.
see. Yeah.
Yes. Yep. Yep. We have the evidence. We know this works. It's time
Yeah.
to make that shift. I have some questions to hand you in just the last couple minutes. I was also very curious about this question, so I'm glad someone asked it. People were curious how long you typically see a patient in outpatient. Let me actually group that together. How long do you typically see a patient and the frequency that you tend to see in
Yeah. And
both an
outpatient.
MS patient and just like in neuro outpatient in general? I'm curious
Yeah.
about that.
In general, most people we see for 2 days a week, so in terms of their frequency. For the duration, it can vary quite a bit. There are some people we see for 10 visits. There are some people I have a few people that I've been working with for 100 plus visits that I've seen for, like, over a year.
Wow.
And so as long as you can continue to show need and continue to show that they're making objective progress, like steady gains, I can keep seeing them forever and ever as long as their
Mhm.
insurance will let me. So there's a broad range there. And then, of course, insurance does limit the amount of visits that somebody can have, much more so than maybe like in an acute rehab setting. So there are some people who would very much benefit from a longer plan of care, would be great candidates for it, but their insurance does not cover it. So those people unfortunately do not are not seen. For our MS patients, depends on kind of where they are in terms of symptoms and disease progression and how they present. I have seen patients for I think 50 or 60 visits. I've seen patients for 30 visits. So it just sort of it varies. But we can, again, as long as their insurance will cover it and as long as I can continue to show that we are making objective progress on our measures, I can see them for a very long time. If they don't need it and maybe they just needed some education on strategies and energy conservation or adaptive equipment or education on, other task modifications and they only need a shorter window, it's okay too. I can see them for 10 visits or 20 visits. But I think that's the range that I have seen for the majority of the people that I have seen, somewhere between like 20 to 30 to like 50.
Mhm. I've never seen a patient with that long of duration, probably because I didn't have, like, the skill set to carry it that long, but
I'm sure that's not true.
I also okay, and for chronic conditions like this, I'm always like, the ideal in my head is that, patients, like, they come back like, almost an annual like, I would love an annual revisit to therapy. Does that actually happen,
Yeah,
in
it
your
can.
setting?
Yeah, it can. We recommend for our MS patients, for Parkinson's or other people with other like progressive diagnoses that they do like a 6-month check in. And even if
Mm,
it's just a quick screen and eval to say, hey, how are things going? Let's reassess some of the objective measures that we were tracking. If everything is still the same, cool. All right, I'll see you
yeah,
again in the next 6 months. If there is a change, then we pick you up for some visits and try to do for some patients for some of our patients we consider it like a boot camp. So try to improve your symptoms and try to get you back up to where as close as you can to back up to where we were. If we need a longer plan of care, let's say there's been you've had more of a relapse or maybe multiple relapses. And so there's a larger change in your functional status. We can pick up for a longer plan of care as well. We ask people to check in as much as possible every 6 months. And so sometimes that can be challenging in terms of scheduling and wait lists, depending on the clinic that you're at. But at our clinic, we are trying to make more space to do that, to make sure that people can get in and be seen. Because for some people, it is just going to be a quick check in, like everything's okay. Cool. All right. I'll see you in
mhm.
6 months.
I love that boot camp model. I've never heard it called that, but I'm like or I've always thought that's the best or like that's the ideal for sure. I have 2 more great, logistical questions. One is about thinking of like a functional medicine umbrella and thinking about diet. I
Mm,
think
mhm.
MS like raises to mind certain diets. Is diet something that you cover as an OT, or does that go in someone else's bucket? What's your experience with that?
I have a little bit. It's not as been as large of a focus within my treatments. But we have talked about it, especially for anybody who have like bowel and bladder management issues, particularly
Mm,
bowel management. So education on things that'll be easier for your body to digest. Education on like times of day, like when you are times of day when you're eating, like those kind of lifestyle management things, specifically diet. Other outside of that, sometimes we'll recommend seeing a nutritionist to discuss with them any other modifications that should be made based on any other health factors that they may have. But I have largely addressed it from more of a bowel management standpoint, and other in terms of lifestyle management.
mhm.
But we
Yeah, I
do
have
we do talk about it.
yep. I have a dream for us where as OTs, we feel really comfortable in the pillars of lifestyle medicine, and it feels like those, like, high level best practices, is where the strong evidence is currently versus, like, condition-specific diets, like, we're not quite there yet, but I
Mhm.
wish we could all, like, up our skills in just, like, core diet
I agree.
conversations.
I agree. I think that would be really great.
Someone also asked about wheelchair positioning and
Mm,
adaptations and any DME recommendations for ADLs. Is that in your bucket,
sure,
as an
sure.
OT? Anything specific that pops to mind related to
Um,
MS?
Let's see. For wheelchairs, we are really cool. We have a nice resource here. We have a wheelchair and seating and positioning clinic, and so I've had patients who come in power chairs, who are again a little bit farther along in the disease progression, so they are not as mobile. So people will come in power chairs with particular seating and positioning systems. For people who need a little bit more support in terms of their ability to manage positioning in the chair, weight shifting, things like that. So, you may want to ask people about getting a rojo cushion or other cushions that may be able to manage that for them if they are not able to do that. A lot of people will come in with, like tilt and space wheelchairs to also assist them with that or recline functions. I have not seen this in practice, but even like the stand assist chairs to help with weight bearing and stance. So you're trying to help people maintain bone density and strengthen their lower body. So there are lots of cool things that can be provided to MS patients. I've also seen people come in just like K5 chairs, so that are the lighter weight ones that are really easy to kind of take apart and put into the car. Very lightweight. They're like the ultra lightweight chairs. We've seen people in like K4s and K3s, which are heavy on the heavier side and have maybe a little bit less capability for modifications to the chair and the seating positioning in terms of like angles of the wheels, angles of the seat back, all of those kinds of things. But you will see people with lots of different setups in terms of wheelchair and seating and positioning just based on what they need. And it may not that may it's more so based on their presentation, less based on MS in particular. But knowing that it's a progressive disease, you want to make sure that you're educating people on these things, especially if they're getting to the point where they are having more mobility challenges. So educating people on what resources there are, what may become beneficial for them later on, even if they don't need it right now. So that would be a good thing to research too. If you don't have access to like a seating and positioning clinic within your outpatient clinic, where they can go to, what that process looks like in terms of getting a referral, how long that may take. So recommending that people get evaluated earlier because that process can take a long time, several months. I've had, some people it can take even longer than that, just depending on insurance coverage and how that process goes. So they may not necessarily need it right at that moment when they're being evaluated, but it may be beneficial later on by the time they actually get the chair. So I hope that part was helpful for the wheelchairs. But for DME, for a lot of the patients that I have seen, there's been more lower body limitations than upper body limitations, and that maybe in the end, yeah, that can change a lot in terms of presentations and where the lesions are, et cetera. And so we talked a lot about bathroom equipment for a patient that I saw previously who he had an accessible bathroom space, but we wanted to make sure that he was able to transfer smoothly. So talking about grab bars and tub transfer benches, even if you have a walk-in shower, a tub transfer bench may actually still be easier, and depending on where you're transferring from. If you're transferring from a wheelchair, a power chair, if you're ambulatory, you may not necessarily need that at that point, but talking about things like that, especially grab bars, long handled sponges, shower heads, long handled shower head holders, to make things a little bit more accessible and easier to reach. But particularly for showers and people with heat intolerance, I would highly recommend that everybody has a chair in the shower, just because people can get very fatigued after taking a shower just because of the heat. And so making sure that they are safe when they are taking a shower. So I would recommend that as a big one in particular. So those are some of the big DME type items that I would recommend. We've talked about long-handled shoehorns, educating people on possibly the need of an AFO if they need one, and so being able to refer out to PT. Because I've had quite a few people who also have who need ankle and foot orthotics just because they're losing some of that control over their ankle, and it's not safe for them in terms of while they are walking. So educating on those kinds of needs as well. So I could go on, but I hope that I hope that answers the question thoroughly.
Oh, this has all been so incredibly helpful. You shared so much just like practical wisdom with us. In our last like 30 seconds, is there one last takeaway that you want to share with us today?
Yeah, I think my big takeaway for MS patients, but also anybody with a progressive disorder, but particularly MS in this case, really trying to encourage and facilitate self-advocacy and having your patients being able to modify the course of their life, their treatment, their diagnosis, and knowing that they can do that's possible. It can be getting diagnosed with a progressive disorder. Any kind of progressive disorder, of course, can be very scary. It can be demoralizing, but giving people hope and saying that there is, this is not necessarily the end. You have a say. Like there are some things that can be done that can improve your condition. Now, depending on their diagnosis, you still need to educate about the potential trajectory, but being able to just kind of inject some hope into that situation to say, hey, we can still try to find a way for you to be able to participate in the things that you enjoy doing and the things that you need to do so that you're still able to, you know, you are still able to best complete the responsibilities of the roles that you inhabit. So that would be my big thing. So self-advocacy, self-management, health management and education are big tools to try to help inject a little bit of hope into that situation.
Well, I just have such a sense today of the hope that you give people and the practical help that you give people. And I'm so thankful that you were here to share with us today. I know if I had an MS patient on my caseload tomorrow, I would feel so much more equipped. And I just thank you for helping us today and providing this guidance. Thank you for being here.
Oh, it's my pleasure. Thank you so much for having me.
Thank you for joining us on the OT Potential Podcast. To earn 1 hour of AOTA-approved continuing education for your time today, you will need to sign in or sign up at otpotential.com. Once you're in the OT Potential Club, you will find a 5-question post-course quiz connected to this episode. When you pass the quiz with a score of 75% or higher, you will be able to download a PDF certificate that certifies your completion of this course. Okay, I want to thank you for joining us today, and we'll see you next time.